So I'm going to stop sharing my screen.
And now we have the pleasure to have Dr. Vargas and his team as well, all the way from Colombia. Dr. Vargas, I think I speak on behalf of all of us that we would love to be in Colombia having this talk in Bucaramanga. But for now, we're going to stay with the Zoom option. But please, it's a pleasure to have you and the team with us again.
Don't forget that words. You should come here maybe for one of our meetings on brain tumors on October. So I let you know when is that meeting, and maybe we can have you here. We'd love to have you here, and of course teach the neurosurgical people here, and of course the students that attend this meeting every week. So I'm going to share my screen. I am here with the students of the University of Santander and Javier Vargas and Annie Jaimes, which are doing a rotation of as in the last year of his medical training, and they are passing 1 month, and during this time they have the opportunity to present some of the literature review of our case. So I'm going to share here the screen. Okay, do you have my screen right now? Yes.
Yes, perfect.
Okay, so we have a patient here that we already start. First of all, I want to speak about those two institutions that we work with, Hospital Universitario Los Comuneros de Bucaramanga and Clínica Chicamocha, and the University of Santander. We are in this campus. You are very welcome, everyone, to come here. This is a male 56-year-old with severe vertigo after a sprain. The patient was working in his rural area, and after a sprain he started with severe vertigo, and of course he went to the doctor, and of course the first thing that the
recording in progress,
many doctors thought was that maybe was something poisoning or something like that. But the patient continued worsening of symptoms, gait imbalance, and did a consultation. So we see the patient 1 month after that situation, only vertigo, no hearing loss really. We did an audiometry. I'm going to show that at the end, and we found hearing loss in the right ear detected by audiometry, but not for the patient. We can see here some of the findings different in comparison this CP angle against this, and those are the main images that I have. And this that we call here Fiesta, sequence Fiesta, that show us maybe the facial nerve here and the tumor. Let me roll out the image, and maybe I can hear some of the comments from the radiologists there. If you can please give a comment about this image that I already showed. I don't know if you can.
Sure. Yes, so I can see the images, and basically, as you said, you call it Fiesta, we call it CIS. This is a very heavily T2 weighted image, and this is very good to find the inner extent of the mass. And the idea is that is the tumor involving the inner ear structures, in which case the approach is translabyrinthine. So preservation of fundal cap fluid. Do we see normal fluid at the fundus cap, or is it obliterated? And The second thing is any enhancement within the inner ear structures. Those two things tend to determine the surgical approach, in my opinion, and whether the inner ear structures are involved or not. So this is a very good sequence. Of course, with people call it acoustic neuroma, but in our experience, the vast majority of these are from the vestibular branch. So we simply use the term vestibular schwannoma for these.
Okay. Yeah, and any comment on this T1? After we see this image, we planning a surgery. As you say, normally as surgeons, we planning to do retro-sigmoid approach going through the cerebellum, this plane, and the planning is to go find a tumor, but also try to remove the tumor since the origin. So we need to take part of the wall of the internal auditory canal in order to take the whole tumor, because I observe many times that the people take the tumor out from the internal auditory canal, but doesn't go inside the internal auditory canal, which is one of the main steps in order to remove completely the tumor. So we use a suboccipital craniectomy. We use a combination of endoscope and microscope in order to do this surgery. Of course, we have neuromonitoring with the plan mainly to identify the seventh nerve, the facial nerve. Depending of the size of the tumor, we remove first intradural, similar that you showed before, when start the intradural removal of the tumor with ultrasonic aspiration, and then we go into the canal and try to remove the tumor from inside. After that, we need to cover the internal auditory canal with some fat, with the take from the patient, and then closing by layers without any problem. Talking about position, this is from the Rotten book that suggests normally the park bench position. Many people use that. Of course, Sami and many people use the sitting position, and we use a supine position with some rotation, maybe more than this, in order to do a retroauricular incision from the mastoid. As shown here, we need to take in account the transverse sinus, which is in the third superior line of the ear. So the landmark for that is we mark the ear, and on the third line division, we mark the transverse sinus, and we do an incision, and we open a craniectomy and remove the bone with air drill, and then after that we enter the cavity. So we have this kind of exposition. We need to take into account this point. This is very large actually for what we do normally. It's important to sometimes see the mastoid veins, sometimes make us a problem, but otherwise it's similar. And after we remove the bone, we have this kind of exposure. We have the cerebellum, and the cerebellum always is like this when we open at the beginning, and we need to be calm and try to push the cerebellum a little bit and try to find some cistern in order to take out the CSF, so we can have a very relaxed cerebellum in order to have a good surgery, trying not to use retraction with the spatulas, but of course at some step of the surgery during microsurgery resection, we need maybe to add some retraction to the brain. So as we can see here, we started always pushing the cerebellum, removing CSF from the cisterna magna, from the cisterns, and then we bring the endoscope to the field. And then we look for this very nice landmark, which is the Tübingen line, which was described by Tata Jiva and Campero, and which always bring us the certain that we are on the internal auditory canal. The flat place that is close to this Tübingen line is the internal auditory canal. So let me show you first the video. So we were entering, and always we bring the endoscope first and then try to see what is the tumor, how is the tumor, and then we work with combination endoscope, microscope, depending. But many times we work with endoscope during the great part of the surgery. So we are advancing, and we see the nerves close to the tumor, the lower cranial nerves, and then we see the tumor. Then in this case we saw this great tumor entering the internal auditory canal, some variation of the tumor. We have the cerebellum here, the facial nerve was identified here, and then we started removing and displacing the tumor very easily, and then remove this dura and take this part of the internal auditory canal, and at the end we have this removal of the internal auditory canal with preservation of the nerves, the facial nerve, the vestibular nerves, and everything. So the anatomy, what we know that we are going to find is this. There is a dural part of the posterior part of the internal auditory canal. We need to remove this bone in order to find the nerves and in order to find the origin of the nerve. And we need to take in account these arteries, because those arteries are very important in order to keep all the structures in place and keep the hearing of the patient. Those are the components of the internal auditory canal: the facial nerve, the vestibular superior, the vestibular inferior, and the intermediate nerve from the facial nerve. Some of the relation, depending of the size of the tumor, if we have a great tumor, almost always, we found the facial nerve on the anterior part, or anterior and superior. Almost never the nerve is against us, so the facial nerve is against our face when we start the surgery. There is another important artery, that is this auditive artery, which is very important to keep in mind. This is the pathology of the patient after removal the tumor. This is a basic stain. The pathology told me that it's classic fusiform tumor, and then we have this S100, which this brown show us that is nerve composition of the tumor. I don't know if the pathologists can help us with this Ki67, these stains.
Yeah, if you go back, if you see here, there are areas that are sort of darker, more pink, and ones that are lighter. So you have ones that are more compact, that would be in Antoni A area. You have ones that are less compact, that'd be Antoni B. At the middle top part of the screen, we see part of a vessel that's sort of cut off dead center in the middle at the very top. So those thick-walled vessels are sort of classic of schwannoma as well. That, in conjunction with the very strong, intense S100 staining, is consistent with a schwannoma compared to other tumor types. And with the Ki-67 being very low, as you showed, that's also consistent with a schwannoma.
Okay, thank you very much.
So we have a little literature review. Vestibular schwannomas are called acoustic neuroma. That is a Schwann cell-derived tumor arising from the vestibular cochlear nerve, especially in the vestibular branch. With the epidemiology, is the third most common intracranial non-malignant tumor, and that accounts for 8% of all intracranial tumors with an incidence of 10.4 per million per year. And when we talk about the CP angle, it's actually 85% of all intracranial growth tumors at the CP angle. Most of the cases have a unilateral presentations, but there's a few cases, 5% of them, that are actually bilateral, and those are associated with the neurofibromatosis type 2 genes that account into that. And some risk factors that we need to take into account are the radiation exposures, and those studies come out from the patients from Hiroshima and Nagasaki, and that were studied from a long period of time, and they found out that the ones that were exposed most of the time with the high doses of radiation presented vestibular schwannomas. We have some clinical features, the common ones and the uncommon ones. The unilateral sensorineural hearing loss that accounts for 94% of the patients, the tinnitus, and the vertigo. Vertigo was actually the main symptom for consultation for a patient, and that's actually a variety in the literature because vertigo is not actually well understood and is not presented in many cases. And then we have the uncommon clinical features that are the hydrocephalus, the trigeminal neuropathy, the facial paresthesia, and headaches caused by and those symptoms are caused by the mass effect of some very big schwannomas that we will talk about later with the classification of the schwannomas. The diagnosis must be done taking into account the symptoms, and there's some literature talk about the brainstem evoked response audiometry that is actually not recommended because of the high rate of the false negative. Actually 30% of them are false negative, and that's due to the size of the brain tumor. Because if the brain tumor is too small, we're not going to have any evoked response from the audiometry. And the MRI, which is the gold standard, and the T1 weighted sequencing being the best among all to see the tumor. What we actually found reviewing this case was that the non-contrast T2 sequence was actually very efficient at seeing the tumor, and it's actually more cost effective. So in a healthcare system that we have, like in here in Colombia, that the patients need to go to the entities to approve their exams, that's actually a very useful tool to identify the tumor. And then we have the diffusion weighted images and very images to compare and try to get to the difference diagnosed that we're going to show later.
Okay, now for the image and grading, it's a common classification system that is very known as the Q's grading scale that is frequently used for vestibular schwannomas. So the Q's grades are designed to stratify the tumor based on the extramural extent and the compression of the brainstem. So, in base of that, the first grade, the Cook grade 1 is a tumor that involves only the internal auditory canal. And so, as we can see in this picture, The grade 1 is a small intracanalicular tumor. The second grade is a small tumor with a protrusion into the cerebropontine system, but this one has no contact with the brainstem. The third grade is a tumor that occupies the CP angle, but this one has no brainstem displacement. And the fourth grade is a large tumor with brainstem and nerve displacement. So now we are gonna talk about the radiological characteristic of the CPA tumors. So as we talked before, the most common CP angle tumor is of course the vestibular schwannoma, that but one of five CPA tumor are not vestibular schwannoma. So the first radiological characteristic of this one is, as we were saying, the ice cream cone shape. But we cannot forget another frequent lesions as the meningioma that has the finding in the MRI, that is the dural tail. We also have the epidermoid lipoma, the arachnoid cystic glomus tumor, and the choroid plexus tumor.
Then this is the hearing findings of the patient. We're speaking about hearing preservation. Those are the pre-op findings of the patient. Some fall on some of the tones, and after the surgery, even the patient is telling us that he's speaking very well, talking by phone, and with preservation of hearing, we can see here some worsening of some of the findings of the audiometry. So even we do with the many special attention, the removal of the tumor, there is some deterioration, but in fact the patient has a very well preservation of the necessary hearing for communication. We try to find in the literature a comparison between radiosurgery and surgery, and really we don't have a good review as we try to find some very nice study that compare really the duration. But on the literature, there are some tendency to say that surgery preserve during more longer time the hearing in comparison with radiosurgery. I wonder, of course, they have the opinion of JP and everyone about this topic. So the teaching points at the end of this case is, of course, the position is very important. The position will be the comfortable position for the surgeon, the well-known position for the surgery, a good anatomy knowledge, use the endoscope and microscope, of course. In many cases with the hearing preservation, the goal should be that, of course, preserving also the facial nerve. Thank you very much, and I open for question. And thank you for the opportunity to allow us to talk on this very nice and very special meeting for us.
Thank you very much, Dr. Vargas. And on behalf of the community and our entire team here, very thankful and very pleased to have your participation, not only today, but in our routine meetings here. So thank you very much for being part of our team. Yeah, we appreciate that. Can you hear me well, or? Oh, okay, just checking. Well, beautiful case. Nice to see how you have in those cases. Then there's always there. I use this for art. We have a good repetitive nerve. The hearing function is way more complicated to be preserved. Once that's said, I think those smaller sizes vestibular schwannomas are the ones that we kind of have to try to push. And as you briefly demonstrate, the in a general auditory canal is a part of the procedure. And in cases like those, in terms of positioning, I also agree with you. Every surgeon has a different preference. We've been doing a lot of it with supine position with the head rotated, but I particularly have tried all of them, and I like all of them. So it goes down to the preferences. But congratulations, amazing talk. And I wonder if some of our team members would like to add questions and comments here as well.
I see Mara Lamotte.
Hi, I have wonderful cases, both of them. So after these cases, I was wondering if there is some genetical marker either for the meningioma or the schwannoma, the same way as for the oligodendroglioma is the mutation in the short arm of the first chromosome and in the large arm of the 19th chromosome.
There are some genetic alterations. The most common is, or one of them common for both the schwannoma and meningioma is NF2. The other one, there are often chromosome 22 alterations in meningiomas as well. So those can be helpful if we have a question as to a poorly differentiated tumor, if we're wondering about the lineage. Those can be helpful, but we don't do those on a routine basis. There are some chromosomal alterations in meningiomas now that are just coming out. One of my colleagues in Rochester is actually doing some work on it. And I haven't seen the specific alterations, but there are some alterations that will indicate more aggressive behavior for meningiomas.
Oh, thank you very much. So there is a preference for histological classification than genetical classification?
At this point, yes. In part, it's because with gliomas, it makes a large difference with prognosis, whereas a schwannoma is typically indolent. It's very, very rare for them to turn into a malignant peripheral nerve sheath tumor. Whereas with neurofibromas, it's rare, but it's much more common for those to turn into MPNSTs than a schwannoma. So in other words, there really isn't a utility at this point. As long as it's morphologically classifiable, that's sufficient at this point.
Yeah, truly understood. Perfect. Thank you very much.
I have one question for JP. When you have a very big tumor and you start to see the tumor, do you start working on the auditory canal or working on debulking the tumor? What for you is the best step to do that?
I usually start debulking the tumor. So usually, like to me, the steps are, I have to say, almost always the same, unless if it is a very small tumor that, that I have to say for the very small tumors, I'd be favoring gamma knife. But, like for the larger tumors, the steps are always the same. So retro-sigmoid craniotomy as demonstrated, opening the cisterna magna and the lateral medullary cistern, trying to identify the lower cranial nerve. So I always find 11 as the first step, and I follow all the way up from 11 into the jugular foramen. After doing that, in those cases, you can already see the tumor that is usually pushing the lower cranial nerves. And then I try to go all the way up to the trigeminal nerve and see if we can open some CSF there. In those cases, most of the time, it's also difficult because the trigeminal is pushed forward by that tumor. So at that point, I start mapping the dorsal aspect of the tumor with 2 milliamperes first, and then I start with the debulking. So those are most of the time the steps that I favor. So I'm a very repetitive surgeon. I don't like changing those.
Dr. Miller, say that. So.
Yes, wonderful case, nice review. You mentioned large tumors, and it brought to my mind. You also mentioned hearing loss. We know that some patients often do lose hearing loss. Even in the, we find that there's loss even in the short time after surgery. Do you aside from having a large tumor which shows obvious mass effect or that kind of a situation, do you use steroids? Do you find steroids to be of any help in preserving? Because it seems like there's some. I assume that the stuff is vascular, but I just wondered what your thoughts were on that, and does it really help any?
You know that neurosurgeons, we always use steroids for anything during surgery, but we need to remind that steroids are not as good as we thought. So many times, of course, after removal of the tumor, we use steroids 2-3 days, and that we stop because we think, okay, we don't do nothing here. But of course, in cases, for example, facial nerve damage, and we preserve the facial nerve, and after the surgery we have this weakness and not good House-Brackman situation. Even if we preserve anatomically the facial nerve, we use steroids, of course, a longer period of time.
Okay, perfect. Thank you.
Yeah, we learned the steroids technique with our dermatology and rheumatology colleagues, so it's steroids for everybody. but jokes apart.
Dr. Diego, nice to see you here, Dr. Diego Mendez.
Oh, Diego. Hi, Diego. ¿Cómo estás?
Hola. Hello, everyone. How are you? I want to congratulate Dr. Vargas' presentation and his team. It was a beautiful lecture. Congratulate also the people in Mayo, João Paulo and Otamendi and everyone there for a beautiful job. This is really a very nice case. I'm sorry for the noise, I'm in an airport. This is a beautiful case where also it comes to my mind the importance of differentiating about the surgical treatment, radiosurgery. I only missed the age of the patient, Dr. Vargas. I'm sorry. What was the age?
In his 50s.
50s, okay. But it was good functional auditory function. And I don't know, I'm completely agree with the approach. I completely agree with the surgical management, but in the literature it continuously comes about the radiosurgery either as a treatment or in the follow-up, and so I completely agree with the surgical because we are at the end, if we have a good functional outcome in the facial and auditory function, I completely agree with it. But it comes into my mind in regarding all the students that are and residents, the role of radiosurgery, so sometimes it's complicated to have that division, but we have to continue doing the surgical treatment with these good outcomes. So I want to congratulate people from Colombia. Okay.
Yes, thank you, Doctor. We try to find if in the literature, of course, if you review only the radiosurgery literature, they speak about the hearing preservation, but a study that compares surgery against radiosurgery is not easy to find on the same size of tumors, but of course we try to do surgery if we can do it in these kind of cases in order to try to preserve the hearing. So we don't send to radiosurgery right away. We try to do the surgery and we have a good outcomes with hearing preservation. I don't know if JP have some opinion on that.
Yeah, no, I fully agree with that. Like in the end of the day, and I like doing radiosurgery quite a lot. I haven't been doing it here at Mayo, but I was doing quite a lot before coming here. And I think radiosurgery is an excellent option for vestibular schwannomas as well. And I think in a case like this, it could be attempted as a treatment option as well. The things that I look when I'm considering treatment options for vestibular schwannomas, of course, the size and location of the tumor, the relationship with the brainstem, the age of the patient, the symptoms presented by the patient. And in order to consider radiosurgery, the one additional thing that I look is the relationship with the cochlea. Because, of course, the smaller the tumor, the highest dose that you can deliver with less risk to the brainstem and less risk to the cochlea. The cochlea, there are some studies that show that if you can deliver radiation, usually with a target of 12 grays to the 50% isodose line to the tumor, but less than 4 to the cochlea, you have a better chance of hearing preservation in the long term. Of course, those are retrospective studies and so on and so forth. But I think that if you decide to do surgery, if we have both options available, and if we decide to do surgery in a case like this, and we had a case similar to yours just yesterday, and the patient has hearing that is functional, we have to push ourselves, surgically speaking, not only to preserve the facial nerve, but to preserve the cochlea and the hearing function in that patient. So for us as surgeons, everybody knows that we usually are initially concerned with the facial, but the facial in this case is no questions asked. We have to preserve it. And now we have to push ourselves to the hearing preservation in those cases. So I agree with you, and I agree with Diego. Important though to keep radiosurgery in mind. If this was an elderly patient with hearing completely gone, I think radiosurgery could be an interesting option as well. And I see your beautiful team, fantastic team you have there in Bucaramanga. I'd like to congratulate you all because we're already past time here for the meeting, but you did an excellent job. And I want you, actually, Dr. Vargas, to end this meeting with some final words. And I'd like to thank Dr. Diego Mendes Rosito for joining us today. And we're looking for you for next week, Diego.
Yes, looking forward for it.
Diego, thank you very much for being here. And no, thank you for the Mayo Clinic team. We want to show you just the things that we can do here in Colombia. And many times we can do, of course, good surgeries, and we try to reach always a good goal for patients and look for improve and try to use our technology and our resources as better if we can do. So thank you very much, JP, for this, and Luis and everybody to help me in order to do this presentation. Thank you very much.
I'm just going to say one thing, Dr. Vargas, not the things you can do in Colombia, the amazing things you can do in Colombia. Being myself a Latin America from Brazil, I know the amazing things we do in Brazil. I know the amazing things that are being done in Colombia, in Mexico, and many other places. I'm very proud of the work that we all doing in Latin America. So congratulations to you and your team. It's inspirational.
Yeah, Dr. Vargas was amazing.
Yeah. Andrea, show us
welcome to Bucaramanga. We need to do this kind of meeting, but here. One Friday here. Don't forget that. We planned that.
Andrea, so you want to show the highlights for next week so we can finish?
Yeah, we will have on Monday we will have the oral presentations presented at Spine Summit. The spine section, we will have Gaetano, Mike Pullen, and the Georgia Tech group. So please join us.
Okay, next Friday we have Dr. Diego Mendes Rosito and his group as well. Thanks, everybody. Appreciate everybody joining us today, and see you next week.
Okay, obrigado, JP, obrigado.
Gracias, hasta luego.